Hello friends, in this video we will discuss some important aspects of pancreas. In pancreatic radiology, we will discuss about acute and chronic pancreatitis, we will talk about the pancreatic head cancers, we will also discuss about cystic lesions in the pancreas. Let us understand by understanding the normal anatomy of the pancreas. We all know the basic anatomy, the head of the pancreas is in close relation to the C-shaped loop of duodenum, right. So, the head of the pancreas lies within the C-shaped loop of duodenum. Then we have the body, the tail of pancreas, and the pancreas is in close relation to the splenic vessels, right. The major blood supply to the body and tail of pancreas, the major blood supply on the dorsal side of the pancreas is mainly by the splenic vessels. And to evaluate the pancreas, CT scan is a better imaging modality. Remember, pancreas is a retroperitoneal structure. So, and to see such deep retroperitoneal structures, better than ultrasound is CT scan. And on CT scan, this is how the pancreas appears. And you can see the splenic vessels just closely related to the dorsal aspect of the pancreas on the posterior aspect of the pancreas. And we will begin our discussion by understanding what is the findings that you see in acute pancreatitis. Acute pancreatitis, we all know, will be a alcoholic patient or a patient with gallstones who is having abdominal pain radiating to the back. So, when you have a alcoholic patient or a gallstone patient coming with severe abdominal pain radiating to the back, what is the investigation you would like to do to diagnose acute pancreatitis in your patient? Remember, the investigation of choice to diagnose acute pancreatitis is serum biochemical analysis, where we try to measure the lipase and amylase levels. And we know that in acute pancreatitis, the lipase and amylase levels are elevated. So, the diagnosis is mainly based on the serum biochemical analysis of lipase and amylase levels. The imaging investigation of choice to look at acute pancreatitis is CECT. And CECT is mainly done to know the amount of necrosis in the pancreas and to look at the complications of pancreatitis, the severity of pancreatitis, rather than diagnosis in the acute condition. CECT is done 48 to 72 hours after the episode. Remember, CECT is done 48 to 72 hours after the episode. It is mainly to look at the amount of necrosis, the severity, the complications of acute pancreatitis rather than diagnosing in the acute condition. The diagnosis in the acute condition should be based on serum biochemical, lipase and amylase levels. And what are the radiological signs that you have in acute pancreatitis? The important radiological signs in acute pancreatitis is the presence of a gasless abdomen. The gasless abdomen is when you take an abdominal radiograph, normally you should see 3 to 4 gas bubbles in the abdomen. But if you see completely gasless abdomen, in acute pancreatitis, you have repeated vomitings in the patient. Because of the repeated vomiting, when you take an abdominal radiograph, you may not see any gas bubbles. So, this is because of repeated vomitings in the patient. Due to repeated vomitings, you may see a gasless abdomen. Sentinel loop sign, this is a small bowel ileus that occurs adjacent to the area of inflammation. So, this is basically small bowel ileus. So, if there is pancreatitis in the epigastric region, there is inflammation happening there. So, the adjacent small bowel loops, they will be in stasis, they will not show peristalsis because that would cause more pain to the patient. So, there is lack of movement or lack of peristalsis of the adjacent small bowel loops in the region of the pancreas, that is called as small bowel ileus, sentinel loop sign. So, it is a non-specific finding. It can be seen in the right iliac fossa if there is adjacent appendicitis. It can be seen in the left iliac fossa if there is adjacent diverticulitis. So, the adjacent small bowel ileus adjacent to the area of inflammation is called as the small bowel ileus, is called as the sentinel loop sign, is the small bowel ileus adjacent to the area of inflammation. And in acute pancreatitis, you will also see colon cutoff sign. The transverse colon will go into spasm, and this will cause, due to colonic spasm, the transverse colon will be distended, but there will be a spasm there. So, no much gas enters into the descending colon. So, this is called colon cutoff, colon cutoff, colon is cut off. So, because of the colonic spasm adjacent to the area of inflammation, you are getting this colon cutoff sign. This is also an important radiographic finding of acute pancreatitis. Renal halo sign, this is seen on CECT, where we see the fluid collections around both the kidneys. There is a halo around both the kidneys because of the peripancreatic fluid seeping around both the kidneys. That is called as the renal halo sign. This is seen on CECT. Let me explain you with the images. Look here, this is what is gasless abdomen. You are taking abdominal radiograph, you are not seeing any gas bubbles. This is gasless abdomen, suggestive of acute pancreatitis. And these are the small bubble loops which are dilated, which are not going peristalsis adjacent to the area of pancreatitis. So, this small bubble ileus adjacent to the area of pancreatitis, this is called as sentinel loop sign. This is also because of the small bubble ileus. It is a non-specific finding. Such small bubble loops in the right iliac fossa, think of adjacent appendicitis. If such dilated small bowel loops are in the left iliac fossa, think of diverticulitis. So, it is a non-specific finding. It talks about small bowel ileus. And in this image, you can see the colon cutoff sign. This is the stomach, this is the transverse colon. And you can see the transverse colon is cut off here. You are not seeing much gas entering into the descending colon. So, the colon is cut off due to the colonic spasm. This is also a feature of acute pancreatitis, colon cutoff sign due to colonic spasm. And this is a CCT image. You can see a halo around both the kidneys. And look at the pancreas, there is edematous inflamed pancreas, and you are seeing the halo around both the kidneys. This is called as renal halo sign, also a CCT finding of acute pancreatitis. So, these are the findings that we have with acute pancreatitis. What are they? Gasless abdomen, sentinel loop sign, colon cutoff sign, and a renal halo sign. The gasless abdomen because of repeated vomiting. Sentinel loop sign is because of the small bowel ileus. Colon cutoff sign is because of the colonic spasm, and the renal halo sign is the fluid collections around both the kidney because of the peripancreatic fluid collections in acute pancreatitis. So, these are the features that you see in acute pancreatitis. And in acute pancreatitis, when you look at the pancreas is edematous, inflamed, and you can see lot of peripancreatic fat stranding, edema around the pancreas. All of this is bulky edematous pancreas, suggestive of acute pancreatitis. So, there is the bulky pancreas, edematous pancreas in acute pancreatitis. And can you see here, there is some necrotic areas, non-enhancing areas, and some enhancing areas in the pancreas. There is a edematous bulky pancreas, but also has some non-enhancing necrotic areas. So, do you think is it an acute interstitial pancreatitis where do we have homogeneous inflammation, or is it an acute necrotizing pancreatitis which has this heterogeneous enhancing and non-enhancing areas? What do you think is this pancreatitis where you have this enhancing and non-enhancing areas? This is acute necrotizing pancreatitis, right? You are seeing the enhancing and non-enhancing areas in the pancreas. And when you have such very virulent acute necrotizing pancreatitis in the patient, it produces lot of tissue necrosis and damage to the adjacent vessels. And the common vessel that is damaged is the splenic artery, because it is very closely related to the body of pancreas. In acute necrotizing pancreatitis, the wall of the splenic artery gets damaged, producing a splenic artery pseudoaneurysm. So, you see this contrast enhancing area in close relation to the splenic artery. So, this is the spleen, just in close relation to the splenic artery, you see this contrast enhancing area, and you can see on the digital subtraction angiography also, you see this dilated area in the splenic artery. So, this is what is splenic artery pseudoaneurysm, a common complication of acute necrotizing pancreatitis. So, if you are given a patient who had a acute necrotizing pancreatitis, after few weeks developing a pulsatile mass in the left hypochondrium, which is showing contrast opacification in close relation to the splenic artery, right? Think of splenic artery pseudoaneurysm in the patient. Remember how the images will appear, how the CCT image appears and how the digital subtraction angiography image appears, showing the dilatation there, the splenic artery pseudoaneurysm. And this is the CT angiography showing you the aneurysm in the splenic artery. So, this is the celiac trunk that is shown to you, and you are seeing the splenic artery having this splenic artery pseudoaneurysm in a patient of pancreatitis. So, this is also splenic artery pseudoaneurysm. So, in acute pancreatitis, if you have fluid collections around the pancreas, based on the duration and whether there is a wall around it or not, we have different nomenclature to the fluid collections. So, if you have a wall around the peripancreatic fluid collection and is generally after 4 weeks of duration, we call this pancreatic pseudocyst. So, pancreatic pseudocyst This usually occurs after 4 weeks of duration. It takes 4 weeks to have a wall. So, it usually has a wall around it. It's a fibrin wall. It's a fibrin wall around it. And because it's a fibrin wall, not a epithelial wall, there is no epithelium there. So, there is no risk of cancer, no risk of cancer in pseudocyst. So, pancreatic pseudocyst does not have a risk of cancer. So, what are the things to remember? It usually occurs after 4 weeks of the episode. It has a fibrin wall around it, and this is a pseudocyst without any epithelial lining. So, no risk of cancer. So, the names of these collections around the pancreas after acute pancreatitis depends on whether it is a interstitial pancreatitis or necrotizing pancreatitis. A interstitial pancreatitis would have a uniform homogeneous inflammation of the pancreas. Acute interstitial edematous pancreatitis will be a homogeneous inflammation of the pancreas without any necrosis in between, without any non-enhancing areas in between. That is interstitial. Whereas necrotizing will be a more virulent type of pancreatitis where you have some enhancing and non-enhancing, some dead necrotic material within the inflamed pancreas. That is a necrotizing pancreatitis. And if you have collection which is less than 4 weeks, obviously it will not have a wall around it. That is called as peripancreatic fluid collection. So, you can remember it as PPFC, peripancreatic fluid collection. This will be less than 4 weeks duration and does not have any wall around it. But if the collection is more than 4 weeks, has a fibrin wall around it, this is called as a pseudocyst. We just learned. So, it is more than 4 weeks and it has a wall. But if it is a necrotizing pancreatitis and a necrotizing pancreatitis which is less than 4 weeks and without wall, this is called as acute necrotic collection. Walled off necrosis is one which is more than 4 weeks, has a wall around it. So, remember, more than 4 weeks and wall, they go together. These two go together, right? More than 4 weeks with wall. And the word necrosis is seen in necrotizing pancreatitis. So, the word necrosis is seen in necrotizing, and which has a wall around it more than 4 weeks. So, walled off necrosis, this is more than 4 weeks duration, has a wall around it. It occurs in necrotizing pancreatitis. If you have a necrotizing pancreatitis without a wall, there is a collection around the pancreas. What do you call it? Acute necrotic collection. You call that as acute necrotic collection. Less than 4 weeks, no wall around it. But if it is an interstitial pancreatitis, less than 4 weeks and no wall around it, what is that suggest you of? Peripancreatic fluid collection. And if it is more than 4 weeks and has a fibrin wall around it, what is that? That is a pseudocyst of the pancreas. So, these are the some important nomenclature you should understand about these fluid collections in pancreatitis. Now, to look at severity of pancreatitis, we use a score called as CT severity index. So, modified CT severity index, this is used to look at the severity of acute pancreatitis. And in this CT severity index, we look at 3 things. We look at pancreatic inflammation, the amount of pancreatic necrosis, and any extra pancreatic complication that the patient has developed. So, we look at 3 things and we make up a total score looking at all these 3 things. Coming to pancreatic inflammation, if there is normal healthy pancreas there, that is given a value of 0. But if you see pancreatic involvement as well as peripancreatic fat involvement, this is given a value of 2. Fluid collections around the pancreas, this is given a value of 4. So, normal pancreas is 0. Any pancreatic inflammation along with or without peripancreatic fat involvement, that is given a value of 2. Fluid collections within the pancreas or around the pancreas, that is given a value of 4. That is about pancreatic inflammation. Now, coming to the amount of pancreatic necrosis. If there is no necrosis, you give it a value of 0. If there is less than 30% necrosis, this is given a score of 2. And if it is more than 30% of necrosis, it is given a score of 4. So, based upon the amount of necrosis that is there in the pancreas. No necrosis, 0. Less than 30% of necrosis is 2. More than 30% of necrosis is given a score of 4. Next, looking at the extra pancreatic complications. So, in acute pancreatitis, you may develop various complications like pleural effusions, ascites, vascular involvement. You may have splenic artery pseudoaneurysms developing. You may have perforations in the intestine. The gastrointestinal complications can develop after a very severe pancreatitis. So, whenever you have this extra pancreatic complications developing, you give it a value of 2. And then we get a total sum, right? If it is coming between 0 to 2, that is a mild pancreatitis. If the value is between 4 to 6, that is moderate pancreatitis. And if the value is between 8 to 10, that is a severe type of pancreatitis. So, 0 to 2 is mild, 4 to 6 is moderate, and 8 to 10 is severe type of pancreatitis. This is CT severity index that is done to look at the complications, the severity that occurs after pancreatitis. And now the next topic we'll study is the imaging findings in chronic pancreatitis. Chronic pancreatitis will have presence of calcification in the pancreas. On an abdominal radiograph or a CT scan, in the region of the pancreas, if you see calcific areas, that is suggestive of chronic pancreatitis. So remember, calcifications are seen in chronic pancreatitis. And chronicity is fibrosis, right? Chronic inflammation leads to fibrosis, and fibrosis leads to strictures and dilatations. And this leads to beaded appearance or tortuous appearance of the main pancreatic duct. So you see a beaded appearance, tortuous appearance or corkscrew appearance of the main pancreatic duct. The stricture and dilatation of the side branches of the pancreas, they lead to chain of lake appearance on ERCP or MRCP images. The distal CBD also undergoes into stricture, that is distal CBD strictures, because of the fibrosis in chronic pancreatitis. The CBD, while passing through the pancreas, it will also get into fibrosis, causing distal CBD strictures. And the medial wall of second part of duodenum is pulled inward. The medial wall of second part of duodenum is also in close relation to the pancreas. So when there is inflammation and fibrosis in the pancreas, the medial wall of second part of duodenum is pulled inwards, producing a reverse 3 sign of Frostberg on a barium study. Let me make you understand this thing. Look at here. This is what is the pancreas. It is having the main pancreatic duct and the side branches that you have. So when you have chronic inflammation of the pancreas, you see stricture and dilatation of the main pancreatic duct, producing a corkscrew appearance or tortuous appearance or beaded appearance of the main pancreatic duct. The stricture and dilatation of the side branches produces chain of lake appearance. It produces the chain of lake appearance. The fibrosis of the distal CBD produces narrowing of the distal CBD, the distal CBD stricture. Because of the fibrosis, the CBD, when it is passing through the pancreas, it gets into fibrosis, producing distal CBD stricture. And because the medial wall of second part of duodenum will also be pulled inward. So this is the second part of duodenum. This is the duodenum, C-shaped loop of duodenum. Because of the fibrosis, the medial wall of second part of duodenum is also pulled inward. So you get a reverse 3 sign of Frostberg when you do the barium study. So when you do the barium, the medial wall of second part of duodenum is pulled inward, producing reverse 3 sign of Frostberg. So what are the findings that you see in chronic pancreatitis? One is calcification. You will see a beaded appearance of the main pancreatic duct, chain of lake appearance of the side branches, distal CBD stricture, and reverse 3 sign of Frostberg on a barium study. So you can see the image here. Look at the CT scan image here. Can you see that the pancreas is appearing atrophic? It is showing atrophic pancreas with presence of multiple pancreatic calcifications. So acute pancreatitis, how was the pancreas? It was bulky, it was edematous. But in chronic pancreatitis, there will be atrophic pancreas with calcification. You are seeing atrophic pancreas with calcifications in the pancreas. The parenchyma is atrophied, but the pancreatic duct gets dilated. The parenchyma gets atrophic, but the main pancreatic duct shows you stricture and dilatations. So you can see here the presence of calcification, and I hope you can notice there is a dilatation of the pancreatic duct. The pancreatic duct shows dilatation. So you are seeing calcifications and dilated pancreatic duct. The parenchyma is atrophic and the duct is dilated in chronic pancreatitis. And here this is MRCP image, and on the MRCP image, what do you see? There is a tortuous appearance of main pancreatic duct. And can you see lot of side branches also dilated? This is called as chain of lake appearance. So chain of lake appearance is also chronic pancreatitis. So what are the other findings in chronic pancreatitis? We see distal CBD stricture and a reverse 3 sign of Frostberg on the barium study. The next topic we'll study is autoimmune pancreatitis. Now talking about autoimmune pancreatitis, this is an IgG4 related condition. And in this autoimmune pancreatitis, you see a diffuse enlargement of the pancreas. You can see that the pancreas is diffusely enlarged, and there is a peripancreatic halo or a rim around it. This diffuse enlargement of the pancreas with a peripancreatic halo or rim around it, giving a sausage shape appearance of the pancreas. So, presence of sausage shaped pancreas, a diffuse enlargement of the pancreas with a peripancreatic rim or halo around it. This is called as sausage shaped pancreas, feature of autoimmune pancreatitis. And we have a criteria for this. This is called as Hissot criteria. You can remember it as Hissot criteria. Hissot criteria. Now, what is this Hissot criteria? There is histology that shows lymphoplasmacytes. There is imaging that shows the sausage-shaped pancreas diffusely enlarged with a rim around it. The serology shows you presence of IgG4, elevated IgG4. Organ involvement is there. The other organ involved, like in IgG4 related diseases, you would have retroperitoneal fibrosis, you have salivary gland, Sjogren's like features. So, all of these involvement of the other organs also will be useful in the diagnosis of autoimmune pancreatitis. And the good response to steroid therapy, the treatment with steroids, this will tell you that what you are dealing with is a autoimmune pancreatitis. So, this is the Hissot criteria for autoimmune pancreatitis. Very good response to steroids will be there. So, what is Hissot criteria? Histology. What does it show? Lymphoplasmacytic infiltrate, and you will see lot of IgG4 cells. Imaging shows you diffuse enlargement with rim enhancement, the sausage shaped pancreas that you have. Serology shows elevated IgG4 levels, and organ involvement, the involvement of bile duct, retroperitoneum, salivary gland involvement, the mediastinum involvement, all these IgG4 related diseases will be there in this condition with autoimmune pancreatitis. And very good response to steroid therapy, right? Very good response to steroid therapy. This is Hissot criteria. The histology showing lymphoplasmacytic infiltration, imaging showing a sausage shaped pancreas, the serology showing elevated IgG4, organ involvements like the salivary gland involvement, retroperitoneum involvement, bile duct, mediastinum involvement, the IgG4 related conditions, and therapy with the steroids, the treatment response with steroids, all of this indicate towards autoimmune pancreatitis. Now, let us understand what is the imaging findings of pancreatic head carcinoma, pancreatic head adenocarcinoma. So, when you look at CA head of pancreas, imagine this is the esophagus, this is the stomach. There will be indentation over the antrum of the stomach because of the CA head of pancreas. This is called as antral pad sign, antral pad sign. And because of an aggressive mass in the head of the pancreas, the C-shaped loop of duodenum appears widened. The C-shaped loop of duodenum is appearing widened. There is widening of C-shaped loop of duodenum. And the mass is in the head, not in the body or tail. It is only in the head of the pancreas, right? In the head of the pancreas. This aggressive mass will produce mucosal irregularity involving which wall? The medial wall of second part of duodenum. This is called as the rose thorning or medial wall of second part of duodenum. The rose thorning or mucosal irregularity on medial wall of second part of duodenum. And this puckered mass, this mass in the head of the pancreas can sometimes pull the medial wall of second part of duodenum inward, producing the reverse 3 sign of Frostberg on the barium study. So, this puckered mass can cause the medial wall of second part of duodenum to be pulled inward, producing a reverse 3 sign of Frostberg. So, reverse 3 sign of Frostberg can be seen in both. It can be seen with chronic pancreatitis because of the fibrosis, or it could be seen with CA head of pancreas. Both of them can produce reverse 3 sign of Frostberg. And the pancreatic duct is dilated, and even the CBD that was coming into the head of the pancreas, this is dilated. So, both this duct, the CBD is dilated and the pancreatic duct is dilated. These two ducts are dilated when you have a large CA head of pancreas. So, you can see a double duct sign in a CA head of pancreas. It is mainly indicative of periampullary cancer because both these ducts have to open into the ampulla of Vater. So, when you have a periampullary cancer, you will get double duct sign, and also when you have a CA head of pancreas. Let me explain you with this image, understand it here. This is the ampulla of Vater where the both CBD as well as the pancreatic duct are opening. So, when you have a peripancreatic cancer, both these ducts will dilate, or when you have a large CA head of pancreas infiltrating into both these areas, these two ducts will be dilated. The CBD will also be dilated and the pancreatic duct will also be dilated. So, double duct sign double duct sign. The CBD and pancreatic duct both are dilated. That is called double duct sign. These are features of periampullary cancers, small cancers around the ampulla of Vater, or a large CA head of pancreas. If it is in the body and tail, only the distal pancreatic duct will dilate, not the CBD. If it is in the body and tail of pancreas, only the distal pancreatic duct will dilate, not the CBD. Double duct sign is feature of pancreatic adenocarcinoma or CA head of pancreas. It is a feature of CA head of pancreas as well as periampullary cancer, not a pancreatic adenocarcinoma in the body or tail. Please remember, double duct sign on ERCP or MRCP is a feature of periampullary cancer. Small periampullary cancers can also produce double duct sign, and also a large CA head of pancreas which is infiltrated into both these ducts. So, first answer should be periampullary cancer. If that is not there in the option, the next answer should be a CA head of pancreas for a double duct sign on ERCP or MRCP. I hope you got this concept. Now, let us actually look at the imaging findings. Here you can see this is widening of C-shaped loop of duodenum. And look at this image. What is this image showing you? A reverse 3 sign of Frostberg. And this reverse 3 sign of Frostberg is seen in two conditions. What were the two conditions? One is chronic pancreatitis because of fibrosis, and which is other condition we learnt? It is in CA head of pancreas. CA head of pancreas. And what is this barium study showing you? There is indentation at the antrum of the stomach. What do you call this? This is antral pad sign. Antral pad sign, also CA head of pancreas. So, when do you see a double duct sign on ERCP or MRCP? Double duct sign on ERCP or MRCP. This is seen mainly in periampullary cancers, right. So, when there is a cancer around 2 centimeters of the ampulla of Vater, the periampullary cancers, or we have CA head of pancreas. This produces a double duct sign on ERCP or MRCP. What do you mean by periampullary cancer? Any cancer which is within 2 centimeters of the ampulla of Vater, that is called as periampullary. It could be a adjacent duodenal cancer, it could be a pancreatic head cancer, it could be in the ampulla of Vater. Anything in and around 2 centimeters of the ampulla of Vater is called as periampullary cancer. They can produce double duct sign on ERCP or MRCP. So, here you can see this is ERCP image and this is MRCP image, and in both these images I hope you can notice the CBD is also dilated, the pancreatic duct is also dilated. The pancreatic duct and the CBD is also dilated because of a mass around the ampulla of Vater. So, this is double duct sign, double duct sign. And where do you see this double duct sign? In periampullary tumors, tumors which are within 2 centimeters of ampulla of Vater. So, they can arise from the ampulla, they can arise from the head or uncinate part of the pancreas, they could be duodenal tumors close to the ampulla, or this could be a distal cholangiocarcinoma. So, any cancer that is developing within 2 centimeter of ampulla of Vater. So, all of these can produce this double duct sign. Please remember periampullary cancers. If you see multiple cysts in the pancreas, this are multiple pancreatic cyst, right. So, on MRCP you are seeing multiple pancreatic cysts. Such true epithelial cysts in the pancreas, you think of von Hippel-Lindau syndrome. This can be seen with ADPKD, but commonly think of von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome will have multiple cysts in the pancreas. Coming to cystic pancreatic neoplasms. The cystic pancreatic neoplasms, these can be serous cystadenoma, mucinous cystadenoma, intraductal papillary mucinous neoplasm, IPMN, intraductal papillary mucinous neoplasm, or solid pseudopapillary tumor called as SPT, or pseudopapillary epithelial neoplasms called as SPEN. So, this can be the 4 types of cystic lesions in the pancreas, either a serous cystadenoma, mucinous cystadenoma, you can have a intraductal papillary mucinous neoplasm, or a solid pseudopapillary epithelial neoplasm. So, let us look at them, each one of them, and also understand the cystic lesions of the pancreas. They are mainly evaluated by endoscopic ultrasound. The investigation of choice is endoscopic ultrasound. So, when you go with the endoscope, you are able to look at the cystic areas very easily in the pancreas. And because you are going with the endoscope, you can actually take a cyst fluid aspiration also. You can go for, because there is a needle attached to it, you can go for a cyst fluid aspiration and study the contents. How is the amylase levels, how is the viscosity of the fluid, and make the diagnosis whether it is a serous cystadenoma or a mucinous cystadenoma. The investigation of choice of cystic lesions of the pancreas will be what? Endoscopic ultrasound. Now, when we look at cystic lesions of the pancreas, it could be due to acute pancreatitis. That collection is the pseudocyst. It could have multiple small microcysts giving a serous cystic neoplasm with a stellate scar in the center. It could be mucinous cystic neoplasm with lot of mucin content inside, mucin rich content inside, or it could be intraductal papillary mucinous neoplasm, and this could involve the main pancreatic duct like this, or it could involve the side branches. So, IPMN involving the main duct or the side branches. So, these are the different cystic lesions that you have. And based on the age group, we can also understand that the lesion that you see in the grandmother, this is the serous cystadenoma. The one which you see in the mother, you can remember M for M, is mucinous cystadenoma. The daughter has SPEN, solid pseudopapillary epithelial neoplasm. IPMN, that is intraductal papillary mucinous neoplasm, this has equal incidence in male and female. So, one cystic lesion in the pancreas which is more common in males is IPMN, intraductal papillary mucinous neoplasm. So, we will start one by one. First, with the serous cystadenoma of the pancreas. Serous cystadenoma of pancreas, we know it occurs commonly in grandmothers, so female populations, elderly females, 60 to 70 years. These have microcystic appearance, giving a honeycomb or a cluster of grape appearance, and they have no connection with the pancreatic duct. If it is connected with the pancreatic duct, you would call it intraductal papillary mucinous neoplasm. But here, there is no connection with the pancreatic duct, without any connection to the pancreatic duct. And what is a classic imaging finding that you have? It gives a sunburst appearance or a stellate appearance, right, with a central scar having the calcifications. So, sunburst appearance or stellate appearance or stellate scar in the pancreas, this is suggestive of serous cystadenoma of pancreas. A sunburst appearance or stellate appearance with a central stellate scar showing calcification, think of serous cystadenoma of pancreas. Let me show you the imaging findings. Such multiple microcysts giving a stellate scar in the center like this, right, having calcification in the center. This is what is a serous cystadenoma of pancreas. Serous cystadenoma of the pancreas. So, that is a serous cystadenoma of the pancreas having a sunburst or a stellate appearance in the pancreas. Coming to mucinous cystadenoma of the pancreas, this we learned is common in mother age groups, so around females around the age of 40 to 50 years. And this mucinous cystadenomas, they are macrocystic, involving the body and tail, usually solitary in appearance. Unilocular lesion with a peripheral rim of calcification may be seen. And there is no communication of the pancreatic duct. Which communicates with the pancreatic duct? Intraductal papillary mucinous neoplasm. Neither the serous, neither the mucinous connect with the pancreatic duct. And multicystic microcyst was serous cystadenoma. Unilocular, solitary, right, with the peripheral rim of calcification. This is mucinous cystadenoma. So, if you look at serous cystadenoma, it is usually in the head region of the pancreas. Whereas, if you look at mucinous, it is in the body and it is unilocular, cystic area with rim of calcifications around it. So, this is lined by columnar epithelium, right, mucin producing epithelium, the columnar epithelium will be there. So, columnar epithelium of the ovarian stroma type will be there. So, this is mucinous cystadenoma. Now, coming to the next one, the mucinous cystadenoma of the pancreas. We learned mucinous cystadenomas are common in mother age group, so female in the range of 40 to 50 years. Mucinous cystadenoma of the pancreas, it is having columnar epithelium with ovarian type stroma, so it is lined by the columnar epithelium. The mucinous cystadenoma is macrocystic, unlike serous. Serous was microcystic. Mucinous will commonly involve the body and tail. Unlike serous, serous is involving mainly the head of the pancreas, whereas body and tail are involved by the mucinous. And this is usually solitary, whereas serous was multiple, honeycomb-like, cluster of grape-like microcyst, but this is usually solitary with a peripheral rim of calcification, unilocular, whereas serous was multilocular, honeycomb-like, cluster of grape-like appearance. Okay, so microcystic appearance is serous cystadenoma. Macrocystic appearance, unilocular appearance is mucinous cystadenoma. And it does not have any communication with pancreatic duct. Pancreatic duct communication is seen with intraductal papillary mucinous neoplasm. So, here you can see a unilocular lesion in the body and tail of pancreas with a rim of calcification, right, peripheral rim of calcification, unilocular, peripheral rim of calcification in the body and tail, mother's age group, all of this is mucinous cystadenoma. This is mucinous cystadenoma. Coming to intraductal papillary neoplasms, the intraductal papillary mucinous neoplasms, these can involve the main pancreatic duct or these could involve the side branches, or it could be mixed type, right, it could be mixed type also. So, if you are having a intraductal papillary mucinous neoplasm, this will have lot of mucin production which is coming through the ampulla of Vater. So, intraductal papillary mucinous neoplasm, they have a communication with the pancreatic duct, either the side branches or the main pancreatic duct. And as the name says, it is intraductal mucinous, lot of mucin production which will be coming out of the ampulla of Vater, which on imaging will appear like a fish mouth appearance on endoscopy. So, fish mouth appearance on endoscopy, this is pathognomic of IPMN, overproduction of mucin coming out from the ampulla of Vater. This is intraductal papillary mucinous neoplasm. And this is seen in elderly patients and has equal incidence in male and females. Commonly, it involves the head of the pancreas, the main duct type. The side branch involvement is more common type of involvement. So, it can be either a main duct involvement or side branch involvement. The more common is a side branch involvement. If you look at malignant potential of the IPMN, this is much more malignant potential. Almost 60% is the risk in main duct IPMN and around 2 to 10% in the side branch involvement. And it also has tall columnar mucin producing epithelium. So, because it is mucinous neoplasm, it has a columnar epithelium, mucin producing epithelium will be there. What is the difference? Mucinous will not be connected with the pancreatic duct, whereas intraductal papillary mucinous neoplasm will be connected with the duct, right. So, as the name says, intraductal papillary mucinous neoplasm. And it goes through dysplasia carcinoma sequence. So, it has higher risk of malignancy out of all the cystic lesions of the pancreas. The IPMN has a greater risk of pancreatic cancer. And which type? The main duct type has higher risk. So, there will be either a diffuse involvement or a segmental involvement of the main pancreatic duct, side branch involvement or a mixed involvement. There could be protruding ampulla of Vater showing a fish mouth appearance, and the side branch involvement shows bunch of grape appearance, but this will be connected to pancreatic duct. And if you look at the malignant potential of IPMN is much greater than that of mucinous or a serous, and pseudocyst does not have any risk of cancer. So, what is the order? Intraductal papillary mucinous neoplasm, serous cystadenoma, lastly is the pseudocyst. Pseudocyst has no risk of pancreatic adenocarcinoma. And if you look at the cyst aspirate that you have done with a endoscopic ultrasound, you have collected or aspirated the cystic fluid, and if you analyze that, obviously pseudocyst, it has lot of amylase and lipase elevated because it is developing after pancreatitis. You will see lot of elevated amylase levels. The viscosity is thin and CA levels, the carcinic embryonic antigen levels will be normal. There is no risk of cancer here. Serous cystadenoma is a serous fluid, so thin viscosity will be there, but the amylase levels will be normal, the CA levels will be normal. Mucinous, this will have columnar epithelium, so they will be having elevated CA levels and they are having risk of cancer also. IPMN, this is also mucinous neoplasm, columnar epithelium, so the CA levels will be elevated. And both of them are mucinous type, mucinous cystadenoma, intraductal papillary mucinous neoplasm, so they are mucin producing areas, so viscosity will be thick. Whereas mucinous, the amylase levels are normal. But intraductal papillary mucinous neoplasm, the amylase levels will be elevated. They are connected with the duct, right? They are connected with the pancreatic duct. So, the amylase levels will be elevated within IPMN. So, that is how we can differentiate. Columnar epithelium, the Ca levels are elevated. Mucin, both of them have mucin inside. So, they will be thick viscosity. Where will the amylase levels elevated? Amylase levels are elevated in case of intraductal papillary mucinous neoplasm and also the one that develops after pancreatitis, that is pseudocyst. So, I hope you can understand based upon the cyst fluid aspirate also, and this you get by endoscopic ultrasound. Now, the last one is SPN, that is solid pseudopapillary tumor or solid pseudopapillary epithelial neoplasm. SPEN you can call it or SPT, right? Solid pseudopapillary tumor or solid pseudopapillary epithelial neoplasm. And which age group we learned this for? This was daughter age group. That means young female, around 25-year-old female. So, females less than 40 years, they have this SPEN. SPEN is common at the tail of the pancreas. You are seeing this pseudopapillary like area, some solid areas, some cystic areas. So, you can see the solid areas, cystic areas in the tail or the distal body of pancreas. So, it is common in the tail or the distal body of pancreas. This is how we have SPEN, and it is heterogeneous with solid cystic areas, right, with some capsule around and calcifications, are slow growing with risk of malignancy. So, suspicious risk of malignancy is there. This is SPEN. Risk of malignancy is highest in which type? The intraductal papillary mucinous neoplasm. The which one? Side branches or main duct type? The main duct type has more malignant potential. IPMN, main duct type, has more malignant potential. So, that is how we have different cystic lesions of the pancreas.